What is going on, everybody? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my cardiology playlist. In previous videos, we talked about angina and myocardial infarction. We talked about hypovolemic shock, cardiogenic shock, obstructive shock, septic shock, neurogenic shock, and anaphylactic shock. We discussed the cyanotic congenital heart diseases and the acyanotic congenital heart diseases, rheumatic fever versus infective endocarditis, acute fibrinous pericarditis versus constrictive pericarditis, dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. We talked about cardiac arrhythmias, and then we started discussing valvular heart diseases. We talked about aortic stenosis and aortic regurg, mitral stenosis, and today it's time to talk about mitral regurgitation. The mitral valve is the valve between the left atrium and the left ventricle. Normally, the blood should flow from the left atrium to the left ventricle and not the other way around. But in mitral regurgitation, it does flow in the opposite direction from the left ventricle to the left atrium. What are the causes of mitral regurgitation? What are the symptoms? How can we diagnose it? How can we treat it? Let's find out. Click the like button, click the subscribe button, because my lungs are already getting congested. This is my cardiology playlist. It has videos on cardiac anatomy, cardiac physiology, cardiac pharmacology, and pathology. Quick review on the normal blood circulation in adults. Oxygenated blood leaves the lungs and goes to the heart through the pulmonary veins into the left atrium, and then the blood leaves the left atrium and goes to the left ventricle through the mitral valve, which is the only heart valve that is made of 2 cusps only instead of 3. Then the oxygenated blood is going to leave the left ventricle and go to the aorta through the aortic valve. This oxygenated blood will be distributed to every organ in your body. The cells will extract the oxygen from the arterial blood, use that oxygen for internal respiration or cellular metabolism, and then dump the waste products and the carbon dioxide onto the venous side. These veins will return the deoxygenated blood back to the right atrium. Then the deoxygenated blood leaves the right atrium and goes to the right ventricle through the tricuspid valve. Then the deoxygenated blood is pumped from the right ventricle to the pulmonary trunk through the pulmonic valve, and the deoxygenated blood reaches the lungs. The lungs will exhale this carbon dioxide, inhale some oxygen, and give it back to the left side of the heart, and you continue again and again and again. Where is the mitral valve? It's between the left atrium and the left ventricle. Normally, it allows blood to go from the left atrium to the left ventricle during ventricular diastole, and then it should close during ventricular systole to prevent the backflow of blood from left ventricle to left atrium. If you wish to see more cardiology videos like this in the future, drop a heart emoji in the comments. How many valves does your heart have? The answer is 4. This is the tricuspid valve between right atrium and right ventricle, mitral valve between left atrium and left ventricle, aortic valve between left ventricle and aorta, and pulmonic valve between the right ventricle and the pulmonary trunk. Here's a question for the pros. There is a tiny ligament here between the pulmonary artery and the aorta. Do you know the name of that ligament? Let me know in the comments. Each one of these 4 heart valves can have pathologies. Pathologies could be stenosis or regurgitation. So there is aortic stenosis and aortic regurgitation, mitral stenosis and mitral regurg, pulmonic stenosis and pulmonic regurg, tricuspid stenosis and tricuspid regurg. What's the difference between stenosis and regurg? Stenosis is difficulty at opening. The valve did not open properly when it should open properly. What is regurgitation then? It is insufficiency. The valve cannot close properly. So failure to open is called stenosis, failure to close is called regurg or insufficiency. We have already covered aortic stenosis, aortic regurg, and mitral stenosis in previous videos in this cardiology playlist, and we're gonna cover everything else later. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. So what happens in mitral regurgitation? The blood backflows from the left ventricle to the left atrium. Why? Because regurgitation is failure to close. Normally, during ventricular systole, the mitral valve should close, but it didn't close. So the blood will backflow from the left ventricle to the left atrium. So you will have lots of blood in the left atrium. And if this is severe enough or chronic enough, all of that excessive blood will end up in the pulmonary veins and then will back up into the lungs. So the patient will suffer from cough that is productive with sputum, dyspnea, which is shortness of breath, paroxysmal nocturnal dyspnea, orthopnea, and sometimes even hemoptysis. Now, since some of this blood is going to the left atrium, therefore, less blood will be available to go in the normal path from left ventricle to aorta. And therefore, less blood will go to the brain, less blood will go to the muscles, etc. So the patient will suffer from fatigue, sometimes pre-syncope or even syncope. And if the kidney receives less blood, oliguria, because of the pre-renal azotemia. Remember the famous slogan, when the kidney has no BP, blood pressure, there will be no PP, no urine, which is called anuria if there is no urine, or oliguria if there is less urine than normal. Every nephrologist should have this bumper sticker. Now, when you ask students, why do we have left ventricular hypertrophy or enlargement in patients with mitral regurg, they have no idea. Why? Short-term thinking. They cannot think ahead, unfortunately. So let's think ahead. Let's think one cycle ahead, or several cycles ahead. In the beginning, the left ventricle pumped and ejected blood to the aorta and to the left atrium because the mitral valve is insufficient. This is stage 1 thinking. What is stage 2 thinking? Where do you think that blood will go to? Well, it can leak back to the lungs, but if it does not leak to the lungs, well, that blood will go from the left atrium to the left ventricle in the subsequent cycle. So let's say that hypothetically, the left ventricle was supposed to receive 70 mL of blood from the left atrium during normal conditions. But because there is regurgitation, the left atrium will have more blood now. There is blood coming from the left ventricle, and there is blood coming from the lungs as normal. So therefore now more blood will be pumped from the left atrium to the left ventricle during ventricular diastole. And instead of receiving 70, I'm going to receive, let's say, 120 mL of blood. Oh, now I have more blood than normal. And according to Frank Starling law, if you give me more blood, if you give me more preload, I will contract harder. I will increase my force of contraction. I will increase my contractility. It's just like going to the gym. The heavier the weights, the greater the muscle growth. So the left ventricle will undergo hypertrophy. Is this hypertrophy caused by volume overload or pressure overload? Mostly volume overload. Therefore, is it going to be eccentric or concentric? Since it's caused by volume overload, it will be eccentric hypertrophy and dilation of the left ventricle. Can we appreciate the left ventricular dilation on EKG? Yes, there are signs of left ventricular enlargement, and you can see this on EKG. Can we appreciate the left ventricular dilatation on chest X-ray? The answer is yes. You'll find an enlarged cardiac silhouette. But the left ventricle is not the only thing that enlarges. Thanks to the backflow of blood from left ventricle to left atrium, the left atrium will also enlarge. And if it enlarges so much, it can compress the esophagus, causing dysphagia, and compress the left recurrent laryngeal nerve, causing dysphonia. The enlargement of the left ventricle will lead to displacement of the point of maximal impulse, i.e. the apex of the heart will be displaced leftwards. And instead of finding it at the left fifth intercostal space mid-clavicular line, it might shift to the anterior or mid-axillary line in your smelly axilla. Now, thanks to the left ventricular enlargement, we might find a palpable thrill or a left ventricular heave or lift. Another point that I want to add, for whatever reason, if we start with left ventricular dilation, dilation causes regurgitation. Why is this? Because when you dilate the ventricle, you dilate the annulus of the mitral valve. And when you dilate the annulus of the valve, you're increasing the risk of regurgitation. So, I have taught my students the following song. Dilation, regurgitation. Dilation equals regurgitation. By the same token, anything that dilates the right ventricle can lead to tricuspid regurgitation. Again, as we have discussed before, if there is volume overload or increased preload on the left ventricle, it shall undergo eccenteric hypertrophy, and we expect S3 heart sound. The regurgitating murmurs, such as aortic regurg, see the previous video, and mitral regurg can lead to S3 heart sound because of the eccentric hypertrophy, because of the volume overload. When the ventricle is dilated, as you see here, this ventricle is good at diastole, receiving blood, but bad at systole, pumping blood. And if the left ventricle is bad at systole, all of this excessive blood will pile up in the left atrium, then in the lungs, leading to pulmonary edema and in some cases even pleural effusion. By the way, if you want to review the anatomy of the heart, check out my anatomy playlist. I have review videos for each subject in anatomy, such as anatomy of the head and neck, upper extremities, lower extremities, anatomy of the thorax, the abdomen, the pelvis and perineum, neuroanatomy, and even embryology. Each one of these topics is covered in 3 separate videos, so when it comes to anatomy of the thorax, there is part 1, quick review, part 2, ultimate review, and part 3, clinically oriented anatomy of the thorax, including anatomy of the heart. Stages of mitral regurgitation. Mitral regurgitation, just like any other valvular heart disease, is divided into 4 stages. Stage A, Stage B, Stage C, and you will never imagine Stage D. Stage A, patient is at risk of mitral regurg. Stage B, patient has progressive mitral regurg. Stage C, severe yet asymptomatic. Stage D, severe and symptomatic. Mitral regurgitation is when the mitral valve fails to close. But when is the mitral valve supposed to close? During systole or during diastole? The answer is during ventricular systole. And that's why mitral regurgitation is a systolic murmur. Between S1 and S2, there is systole. Between S2 and the following S1, there is diastole. Since mitral regurg is a systolic murmur, you're gonna hear it during systole, meaning between S1 and S2. So instead of hearing the normal lub-dub, 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 you're going to hear shtup, shtup, shtup. Where should I put the stethoscope in order to hear the mitral regurgitation? Well, you put it at the apex. And where is the apex of the heart? Left, 5th intercostal space, mid-clavicular line, just half an inch below the nipple. But of course, if the patient is female, you cannot rely only on half an inch below the nipple because the size of female breasts vary. How do I remember that mitral regurg murmur is a systolic murmur? Well, you can do so by understanding that mitral regurg is failure of the mitral valve to close. And when is the mitral valve supposed to close? During systole. And therefore, mitral regurgitation is a systolic murmur. But on the exam, if you do not have enough time to think, you just memorize one word, which is this inappropriate word, meaning aortic stenosis is systolic. And then if you change one letter of these two, you change systole into diastole. But what if I change both letters? For example, the A became M and the S became R. Then you keep systole the same. So aortic stenosis is systolic. Change one letter, mitral stenosis, you change systolic into diastolic. Change one letter, aortic regurg, you change systolic into diastolic. But if you change both letters, A becomes M and S becomes R, you change it twice, systolic into diastolic and then diastolic into systolic, so you keep it the same. It's akin to flipping 180 degrees for one letter and 360 degrees for 2 letters. Here is S1, here is S2. Between S1 and S2, there is systole. Between S2 and the following S1, there is diastole. Mitral regurgitation murmur, just like tricuspid regurg, is holosystolic or pansystolic, unlike mitral valve prolapse, which is usually mid-systolic. Has anyone watched the previous video? Mitral stenosis was diastolic murmur. So the mitral regurgitation murmur is high-pitched, blowing, pansystolic or holosystolic murmur, best heard at the apex of the heart, which is in the left 5th intercostal space, mid-clavicular line, and sometimes this murmur radiates and propagates to your smelly axilla. Types of mitral regurgitation. There is acute and there is chronic. Acute mitral regurgitation is a medical emergency. Why is this? Because the blood is returning from the left ventricle to the left atrium with vengeance during ventricular systole. All of that blood is going to end up in the lungs with vengeance, causing flash pulmonary edema. That's not good. But in chronic mitral regurgitation, this happens slowly, allowing the left atrium enough time to dilate and adapt. sometimes even reaching normal pressure. And how is that possible? Does anyone remember Boyle's law? P1V1 equals P2V2. Let's assume that P1V1 is describing normal conditions and P2V2 is describing chronic mitral regurgitation. Normally, the left atrium has its optimum pressure and it has a certain volume. Acutely, the pressure rises quickly because there is no time for the left atrium to adapt. But chronically, in the beginning, pressure rises. But then the volume of the left atrium will increase even more. And since P and V are inversely correlated, the pressure will start to decrease and back to normal. That's how you end up with normal pressure, because there is a dilated left atrium only in chronic mitral regurg. Next, the effect of mitral regurg on the pressure-volume loops. Normally, we have pressure on the y-axis, volume on the x-axis, hence pressure-volume loops. This maximum volume here is the end diastolic volume, and this minimum volume is the end systolic volume. And what is end diastolic volume minus end systolic volume? We call this the stroke volume, which is from here to here. That's your stroke volume. In mitral regurgitation, what do you think is going to happen? Well, let's draw a left atrium and a left ventricle. Left atrium is here, left ventricle is here. Between them, there is the mitral valve. We have mitral regurgitation, mind you, so all of that blood is flowing back to the left atrium. But enough with this stage 1 thinking, you need to think ahead. All of that extra blood will eventually be returned back to the left ventricle in the next cycle. So therefore, what do you think is going to happen to the volume of the left ventricle at the end of diastole? It will increase. Look at this shift to the right. The end diastolic volume has increased. Instead of this, it is now this. That's a higher volume on the horizontal axis. And according to Frank's Starling law, if you give me more blood, I will contract harder and push forward more blood. So that's why the end systolic volume decreases a little. Instead of this, we have that. And therefore, what do you think is going to happen to the stroke volume? Well, all of this is now my stroke volume. That's a higher stroke volume. Next, what's the effect of mitral regurgitation on the graph that has blood pressure on the vertical and time on the horizontal? Normally, the pressure in your aorta is 120 during systole and 80 during diastole. This red color is the aortic pressure, which is the pressure in the big arteries. How about the pressure in the ventricle, the green color? During systole, it's 120 millimeters of mercury. During diastole, it descends to almost 0. How about left atrial pressure? It rises and falls, rises and falls. This is the jugular venous tracing, which looks something like this. A, C, X, V, Y. Systolic usually rises up to, let's say, 5 and descends to 0 millimeters of mercury. All of this is normal. How about mitral regurg? Well, let's draw a left atrium here and a left ventricle there. Thanks to the mitral regurg, lots of blood is returning to the left atrium, so therefore the left atrial pressure has to rise. Look at all of this rise. When does the rise happen? The rise happens together with the venous return, because the lungs are returning their oxygenated blood back to the left atrium at the same moment that the left ventricle is giving its blood to the left atrium, which coincides with this V wave, which stands for venous return, and that's why you end up with a very tall V wave. If you want me to make a special video on the jugular venous waves or the right atrial waves, please let me know in the comments. Do we have a true isovolumetric phase during mitral regurg? No. Why not? Because isovolumetric means that the ventricle acts as a closed chamber when all the valves are closed. The mitral, tricuspid, aortic, pulmonic are all closed. But since this mitral valve is not good at closing, therefore the heart will never be a truly closed chamber, and therefore there is no true isovolumetric phase. To learn more about isovolumetric phases, watch my video on the cardiac cycle in this cardiology playlist. Here is everything you need to know about mitral regurgitation in one slide. The causes of mitral regurgitation. Rheumatic fever is a cause. Acute or chronic? Usually acute rheumatic fever. Remember, acute with a U is regurg with a U. But chronic is stenotic. Chronic is stenotic. chronic rheumatic fever is more likely to cause mitral stenosis, whereas acute rheumatic fever is more likely to cause mitral regurg. Endocarditis can lead to mitral regurg. Myxomatous degeneration of the mitral valve and mitral valve prolapse can eventually cause regurgitation, and this is the topic of the next video. Keep in mind that one of the complications of mitral valve prolapse is mitral valve insufficiency or regurgitation. Cardiomyopathy. If I get dilated, as in dilated cardiomyopathy, I will get regurgitated. Dilation, regurgitation. Ruptured chordae tendineae or papillary muscle rupture, one of the complications of myocardial infarction, can lead to acute mitral regurg, which is a true medical emergency. Hypertrophic obstructive cardiomyopathy can also give me a mitral regurg for a reason that we will discuss shortly. The symptoms, because there is tons of blood accumulating in my lungs thanks to the regurg, there is dyspnea, orthopnea, paroxysmal nocturnal dyspnea, hemoptysis, and more. Put your stethoscope on the patient's chest, you will hear wet crackles and râle de la mort, the rattles of death. Because the left ventricle is wasting its blood on the left atrium instead of giving it to the aorta, there is less blood in the coronary arteries, decreased coronary flow, which can lead to angina. And there is less blood going to the muscles, therefore fatigue, and other low cardiac output symptoms, including presyncope, syncope, oliguria, cyanosis, etc. Physical examination. Put your stethoscope on the patient's apex. You're going to hear a high-pitched blowing holosystolic or pansystolic murmur, best heard at the apex of the heart and radiates to the axilla. The point of maximal impulse, i.e. the apex, is displaced laterally. Because of the volume overload, we expect S3 heart sound. Because S1 sound is normally caused by the closure of the mitral valve, and this mitral valve cannot close, we have diminished S1. Next, remember that we have S1 and S2, and the S2 is split into two. There is A2 followed by P2. This is normal. But in mitral regurgitation, we have a widely split S2, so the distance or the duration between A2 and P2 is prolonged. Why? Due to decreased left ventricular ejection time, so the A2 happens earlier than it should. Thanks to the left ventricular hypertrophy, we can feel a palpable thrill and a lift or heaving of the left ventricle at the apex. Remember that the heaving of the left ventricle is felt at the apex, whereas the right ventricular heaving is parasternal, not apical. Because, of course, the left ventricle is here at the apex, but the right ventricle is here, parasternal. How can we diagnose mitral regurg? Clinically, by the history, the symptoms, and the signs. And whenever you hear a murmur with your stethoscope, what's the next step? It's to do an echo. Even better if you do a Doppler to look at the flow. When we say duplex, what does that mean? Duplex means double, okay? Double what? Well, you're going to see two things. We're going to appreciate two things. Number one, the anatomy. Number two, the flow. That's what duplex means. On an ECG, there is dilation or enlargement of the left atrium and enlargement of the left ventricle. Chest X-ray, left atrial enlargement, left ventricular enlargement, and if there is pulmonary congestion, the curly B lines. And the cephalization, and the bat wing sign, and the air bronchogram, etc. Even pleural effusion is possible. Cardiac catheterization to confirm the severity of the mitral regurg, because the severity determines the treatment. Speaking of treatment, non-pharmacological management includes restriction of salt and recommend a proper diet and exercise. Medical. If we have signs of congestive heart failure, give loop diuretics to decrease the preload, beta blockers to decrease oxygen demand, ACE inhibitors to decrease the afterload. If there is rheumatic fever, or if we are suspicious or afraid that rheumatic fever is imminent, antibiotics prophylaxis is important. Surgical options. You can try to repair the mitral valve, or if it cannot be repaired, you can throw it in the trash and replace it with another mitral valve. What kind of valve do I replace it with? We have two types. You can replace it with a tissue valve, usually from a pig or another animal. This is known as bioprosthesis. Or with a metallic, i.e. mechanical valve. Each one has pros and cons. We need to start considering surgical options when the left ventricular ejection fraction is low, less than 60%. Let's review mitral regurgitation. Acute mitral regurgitation is a medical emergency. can happen after MI, characterized by flash pulmonary edema. You diagnose all the valvular diseases with echo. Medical management: reduce the afterload with ACE inhibitors, reduce the preload with diuretics. Nitrates may be helpful. Surgical options: we start to consider them when the left ventricular ejection fraction is lower than 60%, or when the left ventricular end systolic diameter is longer than 45 millimeters. Which means that the left ventricle is dilated. It is dilated with eccentric hypertrophy. If you have watched my previous video on hypertrophic obstructive cardiomyopathy, see my cardiology playlist, you would recall that there is an anatomical proximity between the aortic valve and the mitral valve. So what? In hypertrophic obstructive cardiomyopathy, we have stenosis of the left ventricular outflow tract, LVOT, which is subaortic in location. This is close to one of the leaflets of the mitral valve. This can tug on this leaflet and pull it inwards, making it harder for the mitral valve to close during ventricular systole, which can lead to mitral regurgitation. And that's why one of the causes of a mitral regurgitation murmur is HOCM, even though HOCM is not a disease of the mitral valve. See, medicine makes so much sense once you understand what the French toast you're talking about. Diuretics, nitrates, beta blockers, and ACE inhibitors can be beneficial. Learn more about these medications as well as the anti-hyperlipidemics, antiarrhythmics, antihypertensives, anti-anginal medications, and digoxin by downloading my cardiac pharmacology course at medicosisperfectionalis.com. Learn about angina, myocardial infarction, the types of strokes, cardiac arrhythmias, ARDS, acute limb ischemias, the toxidromes, and more by downloading my emergency medicine high yields course at medicosisperfectionalis.com. Learn about cardiothoracic surgery, vascular surgery, neurosurgery, trauma surgery, orthopedic surgery, general surgery, and more by downloading my surgery high yields course at medicosisperfectionalis.com. Each one of my courses comes with videos, notes, and cases. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.